Okay, good afternoon, everybody. And to all of you who are staying on till the final session of BAUS, I think you are going to be rewarded. This is one of the best sessions that we do. I'm honoured to be able to chair it. My name's Jo Cresswell, I work in Middlesbrough, and I am really proud to present a fantastic team of 12 amazing people who are going to give you some updates. In this team, we have a mixture of quite seasoned speakers, but I also want you to know we have a mixture of trainees who maybe are stepping up to this podium for the first time, so I'm sure you'll give them all your full attention. Can I make a special mention of one individual? Unfortunately, Nadir Osman, who is going to be doing the female and LUT session, is unwell, so I send him our best. And I have Aziz Ghulam Hussain, who has very kindly stepped in at the last minute. He's an ST7 from Sheffield to do this session, so thank you very much, Aziz. So, the way the session will run, we have our 6 topics. We have 2 speakers for each topic. The first speaker, their remit has been to tell you about the updates over the last year in their area of expertise. The second speaker has been asked to provide a highlight session of the latest that we've seen at the BAUS meeting. So they're coming up in buddy pairs. In the interests of time, this is quite a complicated session, we're going to save questions till the end. If you would like to text in your questions to the app, then I will ask any questions that I'll be able to see those on the iPad, and I will ask them at the end of the session, provided we have time. Okay, so without any further ado, I'm going to invite Andy Baird and Mark Lucky to step up, and they're going to tell you about the latest updates in andrology and urethral.
Afternoon, everybody. Mark and I are actually going to do it slightly differently to Joe's remit, in that I'm going to give you an entire update for the last 12 months on urethral and other reconstruction, right up to the end of this meeting, and Mark's going to do the same for andrology and sexual medicine. Okay. So we've looked at updates since BAUS last year, updating on the important trials, looking at the main European publications and picking out highlights from there, giving you some information from the EAU meeting in London this year, and then also this meeting, of course. So the open trial, we heard a little bit about the open trial from Rob Pickard earlier today. I think everybody knows what open is. It's a comparative trial of open urethroplasty against endoscopic urethrotomy. Recruitment opened in 2013. Initially a 2-year recruitment phase. It was extended for an extra year. The recruitment phase ended with 22 recruited participants across 53 centres. The follow-up phase is well underway, and the preliminary data is expected at some point. The master trial is a comparative RCT looking at the difference in outcomes between artificial urinary sphincter and the male sling. Recruitment opened in 2014. Randomization continues. There's been an extension to the study to the end of this year. Currently there are 314 subjects across 29 centres against a target of 360. The top 5 sites for recruitment are there on the screen. Bristol 43, UCLH 35, Newcastle 28, and Middlesbrough and Sheffield 19 each. Oh, sorry, Guy's 20, Middlesbrough and Sheffield 19 each. Moving along to the EAU in London, so I've picked out some highlights from that meeting. There were reconstruction sessions in various places. Early in the meeting, there was a poster session looking at urogenital reconstruction. There were several posters discussing various aspects of urethroplasty and other relevant topics. And of particular interest, a review of long-term outcomes of non-transecting anastomotic urethroplasty from UCLH. I'll come back to that a little bit later on. There was also a review or a walk through urethroplasty proms, which are in increasingly common use. Later in the meeting, there was a thematic session on urogenital reconstruction, which was mostly debate and state-of-the-art lectures, with one particular highlight from Margit Fish Group in Hamburg, comparative assessment of postoperative erectile function and quality of life in male 1-stage onlay versus inlay buccal mucosal graft urethroplasties. A poster session on post-prostatectomy incontinence, lots of different posters on the subject. One of particular interest covered aspects of previous incontinence surgery and surgical volume having an influence on social continence outcomes, and this was a large European multi-institutional study. There were 2 video sessions, one on minimally invasive reconstructive surgery, mostly upper tract techniques, and another session on advanced reconstructive techniques, focusing on a handful of rather complex operations, upper and lower urinary tract. Surprisingly, perhaps, only one notable publication in European urology over the year, and that was from Guido Barbagli's group, where they're continuing to glue urethras together, putting a graft in and using tissue glue to secure the graft, which they are reporting good outcomes from. Not particularly been well taken up in the rest of Europe. The BJUI, there were some interesting publications. In September 2016 and then in April 2017, there were publications on the midterm outcomes of the Advance XP male sling. The earlier publication was a single-center review over a 36-month follow-up period, and then a multi-institutional paper from Germany, Austria, and Italy, again with 36-month follow-up, looking at various different metrics and demonstrating statistically highly effective outcomes with low complication rates. In March 2017 and May 2017, there were papers looking at the sling options. So the ATOMS is the adjustable transobturator male sling. This was a large multi-institutional study from Europe, 287 men, 31-month follow-up, reporting 64% continence outcomes, but 90% overall success. There were some debates about how the actual continence was being reported, which is often a contentious issue in continence studies. And then a very small series from a single institution looking at the Virtue sling, which is a Coloplast product. Very early data there. And then moving on to BAUS this year, we had reconstruction content, firstly in the andrology and GURS section meeting at 8 o'clock on Monday morning. The main discussion topics were on national implantation centres, specialist commissioning funding, and the database and audit data collection in conjunction with this association. Monday afternoon, there was a joint session with andrology and GURS, along with the female neurourology and urodynamics section. There were 2 excellent keynote talks, one from Dr. Martinez Salamanca from Madrid, giving his perspectives on artificial sphincters and slings in post-prostatectomy incontinence, quickly followed by Professor Chartier-Kastler from Paris, who I think we probably all know implants a great number of female artificial sphincters for stress incontinence with very good outcomes. There then followed a debate between Paul Anderson and Daniela Andrich about 1-stage versus 2-stage penile substitution urethroplasties with buccal grafts. And then we also heard some outcome data on female urethral strictures from the UCLH group, looking at a paper reporting ventral onlay grafts in female strictures. The main reconstruction session was an e-poster session, session 4 yesterday, covering andrology, reconstruction, penile cancer, and male infertility. I'll just cover the reconstruction side of it. Some highlights were a paper from UCLH looking at long-term outcomes of bladder neck implants of sphincters, 140 implants over a 20-year period, male and female, with mean follow-up of 112 months, reporting, as we all would attest to, surgically challenging cases, but with excellent outcomes. And one of the other main findings is a high explantation rate of 40% compared to bulbar sphincter cuffs. We heard some more detail on the long-term results of non-transecting anastomotic urethroplasties from UCH, 125 cases over 6 years, utilizing 3 slightly different non-transecting techniques, 92.8% subjective success based on patient-reported satisfaction, and 96% objective success based on flow rates and urethrogram measurements. And then there was an excellent paper on, from Sanjay Kulkarni's center in India, Pune, India, reporting on a modified technique for performing MRI scans in pelvic fracture urethral distraction injuries. The team use a technique using a mixture of lignocaine gel and saline in the urethra, and simply using the urine in the bladder and straining to void with the assistance of tamsulosin. And it gives excellent pictures of an attempted void as well as a full urethra, demonstrating the urethral gap. You can quite easily see where the urethral sphincter is in relation to the injury. Very useful for planning reconstructive surgery. So in summary, there have been very few reported developments in urethroplasty surgery over the last 12 months, but the open trial is keenly awaited. In terms of post-prostatectomy incontinence, the master trial continues. There is good emerging data over a 3-year follow-up period of the Advance XP sling. There's some emerging data on some of the other sling products, and there were very few published papers in the contemporary European literature on reconstruction, but I've picked out the main highlights for you there. And finally, just to draw to your attention, the GURS Masterclass in London in November. There's a website link there for you. Thank you.
Right, good afternoon, everyone. I'm talking about andrology, sexual medicine, and the fertility updates. So it's been a very, very exciting year for andrology. Presented at the ESSM was UCH's modified new protocol for the use of collagenase in Peyronie's disease using maximum of 3 injections. They looked at 51 patients with a mean curvature of approximately 50 degrees and showed that there was approximately 20-degree improvement in patients with a very, very high satisfaction rate. So this means that patients were converted from not being able to have penetrative intercourse to having penetrative intercourse. So very good results with minimal side effects, transient penile swelling and bruising. There was no significant adverse events such as corporal rupture. So it shows it's a very, very good treatment, and it's a useful adjunct for treating Peyronie's disease. Also, this was a really interesting study presented at EAU this year looking at the use of tadalafil daily dose for chronic prostatitis. It's quite interesting because they worked on the theory. We know that daily tadalafil has been shown to improve lower urinary tract symptoms in men, and the whole theory was by improving blood flow to the pelvic organs in this complex and very difficult to treat condition. So patients were either randomized to have levofloxacin alone or levofloxacin and daily tadalafil. So basically there were improvements in all scoring groups, and as we already know, tadalafil, there was significant increase in the IPSS score with regards to LUTs, and there was good changes in the prostate symptom score index for prostatitis. So it is something that's very interesting, something that's worth bearing in mind, whether or not it's not currently licensed for this use, but it certainly is something worth bearing in mind for the very difficult cases. Adverse effects, frequent erections, maybe not such a bad thing, dyspepsia and headache. What Mr. Ralph's group presented at this meeting was salvage microscopic testicular extraction of sperm after previous TZ. So this is quite interesting. Although the numbers are small, there's absolutely no published data in this group of men, and it's sometimes very difficult to predict who would be useful to have repeat micro-TZ. What came out of this study is it was a bit of a combination of men with varicoceles, which we do know repairing varicoceles does improve surgical parameters, and it did show a good result from this point of view. Then Mr. Munir's group spoke about CIS in the penis, which is a bit of a contentious issue, but what it actually showed is in surgical groups with positive excision margins, just clinical follow-up is sometimes enough because there was no actual progression. So this was thought to be secondary to keratinization of the tissue. So this is probably an interesting area that we could look at further in detail. Okay, at this meeting we also discussed dogmas in urology, the undescended testes. We decided that 12 months was the ideal age for surgery, should be carried out in a specialist centre with paediatric anaesthetists. Very weak evidence for cognitive impairment for general anaesthetic in kids, just to be aware of if you ever asked about that. And then Mr. Minhas spoke about biopsying indeterminate testicular lesions. Again, that depends on the availability of a radiologist, the centre, intraoperative marking, but it's most useful in lesions less than 5 millimetres and reasonable to observe. Future of urology, specialised centres, which are going to be based geographically, based on numbers and BAUS audit data, centralised commissioning for penile prostheses and microtesie, and andrology training continues to be an ongoing issue with regards to fellowships, how much we need. Thank you.
So thank you, Andy and Mark. Our next two speakers, we have Rob Calvert and Snehal Patel, who are going to give us an update on endourology. Thank you.
Thanks very much. So I've based this talk on a PubMed search for kidney stones and urolithiasis over the last 12 months or so. So around 700 abstracts I've looked at and pulled out things that are, I think, would be most interesting, most relevant, and the most important sort of papers. I've also will mention a couple of ongoing trials and some of the national audit data. So firstly, this study from Oxford is an update from a study from about 5 years ago, which looks at stone incidence. And we can see there was a dramatic incidence up to about 5 or 6 years ago. And while stones are still increasing, it's not at quite the same rate, at least based on HES data. But what we have found is that our lengths of stay have pretty much halved, both for elective and emergency cases in the last 10 years or so. Open surgery is rarely performed now, very small numbers. And whilst the previous publication had looked at the dramatic increase in flexible ureteronoscopy and laser stone fragmentation, actually this has doubled again in the last 5 years. So there's a huge increase in laser treatment for kidney stones. Moving on to this study from the Boston area, the health professional follow-up study with over 3 million person years follow-ups with dietary diaries. We know already that vegetable protein is better for stone than animal protein, and this refines it further, looking at, in fact, dairy protein appears to be protective. One of the most interesting findings from this study was the very protective effect of dietary potassium, and it more than halves the stone risk with higher dietary potassium. And we know this has an effect on urinary pH, so it's hardly surprising. For people who need medications for other conditions, there's been a few large studies that have shown associations. We know that hypertensive patients have got an increased risk, independent risk factor for kidney stones. But if you're prescribed a thiazide diuretic for your blood pressure, you've got a lower risk of future stone formation compared to those people who are prescribed beta blockers or calcium channel blockers. Moreover, for people with low bone density, if you are given a bisphosphonate for this, you have more than a 30% reduction in your stone risk based on this further large study with over 1 million person years followed up. In terms of vitamin D, and vitamin D deficiency is endemic in the north of England and even more so in Scotland. And there is concern in people who have kidney stones and vitamin D, because vitamin D facilitates calcium absorption from the gut. Is this going to increase the stone risk further? And a few studies have looked at this, and it appears that vitamin D replacement doesn't specifically increase your stone risk. Over the last 5 years or so, there's been a renewal in an interest in Randall's plaques, partially due to the fact that we are now seeing inside kidneys much better, and we realize that Randall's observations from 75 years ago that about 2/3 of kidney stones, of calcium kidney stones, are formed in association with one of these interstitial papillary plaques. Focus in kidney stone prevention has been very much on trying to manipulate urine biochemistry, both by diet and by medications. But if we're really going to prevent kidney stones, we really need to understand why the Randall's plaques form. And there have been a number of studies looking at that over the last year. And I've just picked out 3 here. C et al., which looked at the flow mechanics and the concentration gradients around the tip of the loop of Henle. There have also been nanoscale analysis of incipient plaques, looking at crystal formation in the interstitium. And there's also been genome profiling of patients with plaques looking for candidate genes. And this is an area to watch in the future for kidney stone prevention. Darren Smith has cited these trends last year. PCNL is getting smaller and flexible ureteroscopy is getting bigger. And there have been a couple of comparative trials over the last year looking at mini PCNL, but I picked this systematic review that looks at a number of randomized and non-randomized trials. When I say PCNL is getting smaller, what I mean is mini PCNL is being used. And certainly for the intermediate size stones, this seems to be a good option. This study shows, published in the European Journal, shows that stone clearance rates are equivalent. However, standard PCNL, or as Jonathan Glass calls it, PCNL, is quicker. The hemoglobin drop is less in the mini PCNL, and this systematic review and meta-analysis didn't actually show a difference in length of stay. But probably the true comparator for cases for mini PCNL is probably the flexible ureteronoscopy for the larger stones. And this data was presented in our section meeting in September from the national audit, over 3,000 cases at that point. And we can see our stone clearance rates for the larger stones are pretty respectable. And the lengths of stay are certainly much less than we're seeing on the national audits for PCNL. And this patient group between 1 and 2.5 centimeter stones is being targeted in the randomized study, the second arm of it, in the PURE study. And as you can see, there's quite a large number of centers already recruiting around the UK. There are ambitious recruitment targets for this, but I would encourage everyone to try and find patients for this study. There have been a number of studies that look at emergent treatment, and what that means is getting the stone treated when they come in with a ureteric stone then and there, rather than putting a stent in and coming back. There has been a little bit of anxiety whether they may not do so well, whether the surgery might be more complicated, but this systematic review does not support that. These people tend to do as well in terms of stone-free rate and complications, both for ureteroscopy or for emergent shockwave lithotripsy treatment. And more importantly, they avoid the stents for prolonged periods of time whilst on waiting lists. The Endourology Society has reported on their series with bilateral same-sitting ureteroscopy, and they do not find any difference in complication rates. In terms of pediatric stones, for many years, shockwave lithotripsy has been the mainstay of treatment, but there certainly appears to be a trend towards more flexible ureteronoscopy and laser fragmentation, even of kidney stones, with miniaturization and improvement in technology. And this French study shows, non-comparative study albeit, shows much improved clearance rates with flexible ureteroscopy. And the final study I'm going to look at is this national database study from New Zealand with 10,000 cases for shockwave lithotripsy, which retrospectively asked the question, do the patients who are given antibiotics, are their infection rates any lower? And their answer was no. The urosepsis rates, albeit very uncommon, were 3 times less common in the antibiotic group, but even at 10,000 patients, this didn't quite reach significance. So before I hand over to Snehal, I'd just like to give a plug for the BAUS Operative Residential Course for Endourology, which we're hosting in October in Liverpool. Applications are on the website, so if anyone would like to final year trainees with interest in stones or lap, please apply. Snehal.
Right, ladies and gentlemen, Snehal Patel from the Wirral. I'm going to give you my thoughts and highlights from stone endourology for this year's BAUS. So following on from Rob's theme there, stones are rising. This first paper from Brighton and Frimley Park, again confirming that using HES data for England, showing a 34% rise in stone incidence over the 10 years. 2 key concepts here, that the steepest rise is in the elderly population, the 75 plus age group, and the concept of geographical hotspots. I think better understanding of these types of data will help us plan stone services in the future and should be borne in mind. Now, diagnostic, we've got a great test. The CT-KUB is a fantastic diagnostic test for stone surgeons, very accurate. But this paper identified that 80% of patients are being over-radiated by a CT-KUB by simply not following the recommended protocols and over-scanning the amount of the body. So I look forward to the follow-up to see how that quantifies in doses and how they've managed to rectify that. But what about the surgeon? Fantastic paper from Ben Horsburgh from his time in Liverpool, showing that the surgeon needs to be considered a lifetime of endourology using an image intensifier. You're putting yourself at risk. Sitting for ureteroscopy is bad. An increased exposure to external genitalia of 80% when you're sitting to perform this. A better understanding of the image intensifier will greatly reduce your risk to both the surgeon and the patient. For example, greater use of iris collimation, reducing the pulse rate and bringing the receiver closer to the patient. Acute stones, Rob talked about the need for quicker primary ureteroscopy to improve the quality of life of patients. And this snapshot from the NUC group showing over a year, showing how we manage 80% of patients conservatively, not unreasonable, but 40% of those patients were documented to have MET. And as you know, that's something that we don't particularly support in light of recent studies. Only 1.4% of patients in this group had an acute ureteroscopy, which probably reflects certainly some close to what we do on the Wirral due to logistic issues. And unsurprisingly, the greater the stone size, the higher the incidence of needing intervention and being tubed. Also, the higher the risk of having a stent or a stone at 6 weeks or more, and also the higher the readmission rate. So the question is, why aren't we doing this more? Graham Watson's team from Eastbourne tried to answer this and say that you can do more. They found that 92% of patients were having expeditious primary ureteroscopy with good stone-free rates and good outcomes and low complication rates. And they were challenging the traditional paradigms of the acutely infected stones, and after a short period of decompression and sepsis management, were going on to have primary ureteroscopy in the same admission with good results. Shockwave lithotripsy. As Rob said, flexible ureteroscopy is doubled, but shockwave lithotripsy perhaps fallen out of favour somewhat. But an excellent paper showing that a dedicated stone service can deliver good results for the ESWL. This paper for an upper ureteric stone, 74% stone-free rate. Again, challenging the traditional paradigms. A high skin-to-stone distance suggests that you'd have a poor ESWL outcome, but here they're saying that you can do it in an obese population. Moving on to PCNL, a good balloon debate, or not balloon debate, but a debate about how we do it. And as a general population, we are a maxi, perk, multi-track, prone PCNL group that like to leave nephrostomies in. But the take-home message from these excellent debates was that you should choose your armory carefully based on the careful case selection to get good outcomes. The BAUS PCNL registry turned out 2 great papers. Again, the obese population, 75% of patients that we do PCNL on in this country have a BMI over 30, and that using the data from that, we can counsel our patients better for this population group. Spina bifida, a complex cohort to start with. Only 88 patients having, out of this 4,000 patient review, having a PCNL, but unsurprisingly in this complex cohort, higher complication rate, higher lengths of stay, and poorer stone clearance rate, and a good case for centralizing expertise for these complex patients. The 88 patients were operated in 40 different centers. Again, Prof. McClinton gave us a good update on the tissue and pure study off the back of the successful SUSPEND study. And we hopefully will recruit that and get some data from the tissue study certainly next year. Finally, how do we sustain excellence in stones? Well, this paper started to allude to key performance indicators and benchmarking such that we can monitor performance and strive for excellence in endourology. Thank you.
Okay, thank you very much to Rob and Snehal. I now want to invite Sheila Reid and Aziz Ghulam Hussain, who are going to cover female urology, but I've also asked them to cover lower urinary tract symptoms as well. Welcome, thank you.
Good afternoon. my remit is to update you on what's happened this year in female and neurourology and LUTS. It's been quite an exciting year, actually, and I've had to really pick out the main things that have been happening. So I've picked out 3 areas. I'm going to talk to you about the ongoing update, what's happened with the vaginal mesh issues. I'm going to talk to you about some of the major ongoing and published trials this year, and then just talk to you a little bit about some of the BPH innovations that have come in this year. So as regards mesh, I can't believe there's anybody in the audience who isn't aware of the major issues that have been going on with intravaginal mesh insertion, both for prolapse and stress incontinence. This year, there's been 2 big Lancet papers published on this, and the Scottish Mesh Working Group have presented their final review, and I'm also going to update you on what's happening with NICE. So the 2 papers that have come out, the first one was published in the Lancet in January 2017, and this was the results of the PROSPECT study. PROSPECT was a big randomized controls trial with 430 women in each arm, randomized either to a standard repair for prolapse or to the use of mesh augmentation or graft for their prolapse. And what it found was that the augmentation of a vaginal repair with mesh or graft didn't improve the outcome. And in fact, more than 1 in 10 women had a mesh complication. Second paper that was published, this is a huge paper. This was published in February 2017. And it looked at the safety and efficacy of vaginal mesh for treating stress urinary incontinence. And this paper looked at more than 16,000 women. All those women had had first single incontinence procedure over the period of time between 1997 and 2016. And the data was taken from the Scottish Hospital Discharge Database. Of that group, 79% had had a mesh procedure. And the take-home messages from this paper are very reassuring. They have shown that the mesh midurethral slings are equally as effective as colposuspension. You'll note they specifically mention colposuspension, and that's because the largest non-mesh procedure in that group was colposuspension, but they did look at all the other stress incontinence procedures. They found that those who'd had mesh midurethral slings had fewer immediate and similar late complications out to 5 years. They found that retropubic mesh midurethral slings had a relative risk of immediate complication that was 50% lower than the non-mesh alternatives. And the outcome quoted is that for reconstructive surgeons who work in women's health, this is a conclusion to be shouted from the rooftops. Then in March 2017, the Scottish Independence Review came out with its recommendations for the use of mesh. And they concluded that retropubic mesh was a valid option for treating stress incontinence. If you're using synthetic mesh, a retropubic approach is recommended, but that all non-mesh alternatives should be offered, and mesh should not routinely be offered for pelvic organ prolapse. MDT working, audit, and reporting of adverse events is mandatory. And you think that it'll all be great, that'd be the end of the story. It really isn't. After this review was published, there was a lot of people who didn't agree with it, and 2 of the patient members and 1 of the consultants on the review committee quit the committee, and they've now called for a review of the review. So we'll wait for next year. NICE have convened a committee, and they're looking at urinary incontinence and pelvic organ prolapse in women. So specifically, they're looking at these issues, and that's supposed to be published in February 2019. And just to say, the public and the media certainly haven't forgotten about this. These are the papers I have found. These have all front page papers come out since March of this year. Just to reiterate, as particularly on this issue, if you are doing female stress incontinence surgery, you must be submitting your data to the BAUS database, and we have had some updates on that at the conference this year. So just looking at the trials, I've just picked out 3 of the big trials, Upstream, Alter, and Rosetta. Rosetta's just been published. So Upstream is a study, Marcus Drake is the chief investigator. They're looking at the use of urodynamics for prostatic surgery, randomizing men who are due to have prostatic surgery into having urodynamics or not. And that is due to recruit right up till 2019. We heard a little bit about Ultra this morning. This is alternatives to prophylactic antibiotics for the treatment of recurrent urinary tract infections in women. It's looking at methenamine or Hiprex, and that is due to close theoretically October, though I understand that might be extended. This trial has just been published. This is a brilliant trial. This is published in Journal of Urology, October 2016. And it's the first time we've actually had some sort of concrete data looking at sacral neuromodulation versus onabotulinum toxin. And they randomized, these were all for women with idiopathic detrusor overactivity, and they randomized 380 women into each group. The important things to realize is the dose of botulinum toxin is 200, which is probably higher than most of us are using for idiopathic detrusor overactivity, and they looked at the results of 6 months. I think the first thing to say is that both treatments gave a significant improvement in the mean daily episodes of urinary urge incontinence and improvement in the OAB bother scores, but Botox gave a better improvement. Specifically for complete symptom resolution, Botox was giving a 20% resolution, whereas neuromodulation was only given a 4% resolution. However, not unexpectedly, Botox has got an increased risk of complications, specifically urinary tract infection and the need for transient catheterization. I must say I'm rather surprised at how low the rates of catheterization are for 200 units of Botox. You'll see there's only a 2% catheterization rate at 6 months. And that's the graph for improvement in urinary urge incontinence, the red being the neuromodulation and the blue being the botulinum toxin. Right, those of you who were at the sessions this morning will have heard quite a lot about this. There is really been a significant move forward for alternatives for TURP this year. I'm going to talk to you a little bit about UroLift, prostatic artery embolization and aquablation, specifically what's been published this year. So this is UroLift. You'll see in the bottom left-hand corner before and after surgical picture. There is 5-year data published, and this year the 2-year randomized controlled trial data came out in the BJUI, actually the end of last year, and it shows similar outcomes to TURP, better return to normal activity, and maintain preservation of sexual function. Also worth noting that the Innovation and Technology Tariff is now applied, so it may actually be financially beneficial to start offering, and you can still offer a TURP or HOLEP if the procedure fails or the patients get deteriorating symptoms. Prostatic artery embolization, we heard about that this morning. Just to say there has been one published paper. It was published at the end of last year in the Journal of Vascular Interventional Radiology. It had a meta-analysis of 167 patients. However, these were between 4 cohorts. Some of those cohorts had very small numbers, and the follow-up is only short-term. Aquablation, that's got to be the best name ever. Aquablation made the front page of Journal Urology this month. This is June 2017. And I'm sure everybody heard the talks this morning. It's a high-velocity saline stream or an aqua beam, and it produces a high pressure to produce a cavity in the prostate. And there's going to be some further updates from my colleague regarding some of the results that were presented today. So that's all I have to present for you. I'm going to pass on to my colleague, and I just once again to reiterate my thanks to him for stepping in at the last minute. Thank you very much.
Good afternoon. Thanks for all the introductions. My name's Aziz. I'm from Sheffield. Just going to spend 5 minutes talking through the highlights of BAUS in the context of female urology and LUTS. Quite a few key areas discussed. I'll touch on as many as I can. Vaginal mesh is still obviously an ongoing problem with regards to the management of the complications, and we've had some excellent talks at the beginning of the week with regards to that, and a session on the medical legal aspects in that context. We've had a presentation from Nikesh Thirachelvan and Sophia Cashman on the outcome data from stress urinary incontinence procedures. The conclusions from that were twofold. One, we're still lagging behind in terms of numbers of procedures uploaded. I think that figure is in the order of 70% in comparison to HES data, so room for improvement there. With regards to surgical outcomes, there didn't appear to be a significant correlation in terms of numbers of procedures performed. We had a talk from Professor Victor Nitti on Monday and subsequent e-poster sessions on female urethral strictures and the management of them, and some figures on the impressive outcomes of the use of buccal mucosa urethroplasty to treat them. Lots of discussions both on old techniques and new techniques of managing LUTS BPH, and an excellent debate this morning. I've picked a few of the papers or the posters presented. There are quite a few, so within the time constraints, I've only managed to get a few in. We had a presentation from UCLH on the surgical management of mesh complications on 56 patients with proven erosion or extrusion. The key points from that were that open excision was associated with a higher success rate in comparison to endoscopic treatment, although that is a viable option, in particular with bladder erosion. The surgical technique, as usual, tends to involve the use of healthy tissue and the use of an interposition flap. 60% of them had persistent or recurrent incontinence post-treatment, however. The surgical management of female urethral strictures, again from London, presented on 22 patients undergoing buccal mucosal grafts. And the outcomes of those patients were significant improvement in flow rates and residual volumes, with good medium-term outcomes at just under 2 years and little in the way of complications. Moving on to LUTS, lots of interesting discussions about improving on sort of day case procedures, and there's a presentation with significant numbers of 700 patients undergoing TURP as a day case, of which 80% had it as a day case procedure. With low transfusion rates, however, there was a mention of fairly significant readmission rate within 30 days and a higher rate of urosepsis, which was unexplained in the day case procedures. Obviously, some implications with regards to setting up the service and making that happen, but some good results there. Following on from what Sheila mentioned about aquablation, there's a presentation today and some results on the water study, which looked at 275 patients between 45 and 80 years old, and prostate volumes of between 30 and 80 grams. So a multi-center study. Early results only, but at 6 months, it was found to be non-inferior in terms of IPSS score, Qmax, and post-void residual, and superior to standard TURP at 3 months, in particular with regards to sexual dysfunction. The competitor, Urolift, equally some good results presented today. 70 patients undergoing Urolift, importantly under a local anesthetic or sedation only, and so implications there with on hospital stay and cost. Results were good, and all patients were treated as a day case procedure. Significant cost implications compared to TURP. So the take-home messages, ongoing problems with mesh complications, they can be managed well, particularly in high-volume centers, so surgical management is achievable with good outcomes in expert hands. Female urethral strictures are uncommon, but can be managed equally well with reconstructive surgery. Figures are low, but suggest that works quite well. A fun debate today about surgical management of LUTS BPH I think the general consensus from there was TRP was still on top, but I suspect that will change as we get more data from the new emerging techniques and more people taking them on. Thank you very much.
Thank you, Sheila. Thank you, Aziz. Do ask any questions. I'm delighted you think that the panel is smartly dressed. We can handle intellectual questions if you can think of any. And I'm delighted now to welcome Alex Colquhoun and Hazel Warburton, who are going to enlighten us on bladder cancer.
Good afternoon. It's my pleasure to give the update this year on what's the most interesting topic, undoubtedly, in urology, and that's obviously bladder cancer. So, a bit like previous authors, there's a huge literature that comes out on a yearly basis. So, over the last 12 months, there were around 1,500 abstracts that had the mesh term of bladder cancer in. So, I've been quite selective and picked 4 topics which I think were most of interest. So, we're going to start off by looking at immunotherapies and their role in the treatment of metastatic bladder cancer. Immunotherapy is not new, it's been around for a long time. We've been using BCG for over 20 years to treat bladder cancer. But the current interest in immunotherapies comes from a rejuvenated interest in the use of checkpoint inhibitors, which modulate T-cell mediated anti-tumor activity. So there's a schematic here. Essentially, bladder cancer is a very highly mutated tumor, and that means it's liable to T-cell mediated cell death. So lots of cancer cells have developed mechanisms to try and avoid T-cell mediated immunity. So they express a number of so-called checkpoints on their surface, so programmed death ligand 1 and programmed cell death proteins. And these allow them to evade the activity of cytotoxic T cells. So the checkpoint inhibitors work by inhibiting these co-regulatory signaling molecules. There are lots and lots of these agents about. They're thought to work in bladder cancer because bladder cancers express the co-signaling molecules. When I last looked, there are currently 52 trials registered with clinicaltrials.gov, just specifically assessing immunotherapies in bladder cancer. And I'm just going to talk about the 3 that have been published in the last 12 months. So there are 2 phase 2 studies, and the reason that these are important is that they form the basis of FDA approval for use of these medications. Both of these trials were assessing anti-PD-L1 molecules, and they were in the metastatic setting in patients who'd had first-line treatment with chemotherapy. And the 2 papers showed fairly similar results. There was an objective response rate of around 15 to 20% with these medications. They were well tolerated, and they seemed to be more effective in patients whose tumors expressed PD-L1. And for the patients who did respond, the response appeared to be durable. The nivolumab study was very similar, showed similar results. Subsequently, there's been a phase 3 study published, which was a randomized controlled trial, and that compared the use of pembrolizumab, and patients were randomized to either receive the checkpoint inhibitor or second-line chemotherapy at the discretion of their oncologist. And the takeaway message from this is that for the first time, they showed a difference in median overall survival in this group of patients for whom the prognosis hasn't changed for several decades. Now, the difference in median overall survival was very modest at a couple of months, but it was significant. Interestingly, this time, though, the survival benefit wasn't modulated depending on whether you expressed PD-L1 or not, so we're not entirely clear what the mechanism of action of these medications is. The other thing to say is that the medications are well tolerated, so the severe toxicity, grade 3 to grade 5 toxicity, is much more favorable than that from second-line chemotherapy. So I think for the immunotherapy papers, I think it's very exciting times. We haven't shown a change in survival for many years, and I think we're going to read a lot more about them over the next 12 to 24 months. We don't know which cohort of patients to use them in, and we don't know which combinations to use together, and I think that's the data that will come out over the next couple of years. Several of the agents are having nice technology appraisals at present because they're not currently licensed for use. So, moving to something slightly different, you sort of can't talk about bladder cancer at the moment without talking about robotic surgery. And I'm just going to talk about a trial that was presented at the AUA last month. So the RAZOR trial was a randomized controlled trial comparing robotic cystectomy with open cystectomy, but with extracorporeal urinary diversion. It's a multi-centre, non-inferiority study that was powered to show that robotic surgery was not more than 15% inferior to open surgery. And their primary outcome was looking at 2-year progression-free survival. So the sort of money shot from their trial, so on the left is the 2-year progression-free survival, and there's no difference between the two arms. And then their secondary outcome of overall survival, again, no difference between the two arms. The other pieces of information that were derived from the trial, well, apart from there being no difference in progression-free survival that we've just seen, patients who had robotic surgery, slightly oddly, had a significantly higher soft tissue margin rate. And those two pieces of information sort of don't really go together, because your 2-year progression-free survival, if we follow traditional dogma for surgical oncology, if you have a positive margin, you would expect to have progressed by 2 years. The other piece of information that we derived from it is the expected that the blood loss was lower and the transfusion rate was lower in the robotic arm. And the robotic arm had a shorter length of stay, but I would question how meaningful the difference between 6.5 and 7 days is. So moving to something slightly different, I get a letter every couple of months from GPs asking me about whether they need to change patients' diabetic medications because of the potential risk of bladder cancer. And there have been several publications over the last 10 years on this, but in the last 12 months there were 2 large case control trials that were reported. The first one in the BMJ, and it was a multi-centre, 4-centre study where they took national diabetic registers, and there were several tens of thousands of patients in these studies, and there is no increased risk of bladder cancer in patients who've been treated with pioglitazone. That was also borne out by the second study that I've mentioned, the PROACTIVE study, which was a 10-year follow-up of actually the vascular effects of pioglitazone. And they again looked at the incidence of bladder and prostate cancer, and there was no effect from the diabetic medication. So I think we can summarize that really it was an epidemiological finding that really doesn't have any basis. Moving on, I've sort of titled this outcome assessments because it's a bit of an eclectic group of studies. The first one I put in was mainly thinking about our own BAUS cystectomy data set, and we're thinking about what things we need to measure. So this was a group who looked at different factors that were predictive of 90-day mortality, and they found from a number of factors the only things that were significant in predicting 90-day mortality were age, ASA grade, and Charlson score, which obviously is interesting to us because the Charlson score is one of the factors that we do record. Of those 3 factors, ASA in fact has the strongest predictive effect on 90-day mortality, and there's a relative risk of 6.7 if you were ASA 3 compared to ASA 2. The next paper was looking at how should we follow up patients who've had cystectomy to look for recurrent disease, and there were a couple of fairly large series that looked at the difference in presentation between symptomatic and asymptomatic recurrence. And in both of the publications that I've cited, there was asymptomatic recurrence was associated with a better outcome, so longer time to death, and also higher chance of receiving adjuvant therapy. The 2 papers at the bottom I put in because they were both meta-analyses, one by an Italian group and one by an Australian group, looking at health-related quality of life in patients by different types of urinary diversion. And I put them in because they showed exactly opposite results, but they derived all their patients from the same studies for the meta-analysis. So the differences are very small in these studies about quality of life. And the take-home message actually from both papers is the patient's engagement in the decision about urinary diversion is more predictive of higher quality of life scores rather than the specific technical type of surgery that's been done. And then the final paper I looked at is something that's EPUB ahead of press, and I thought it was relevant and topical for us to think about, and it's thinking about what the effects of the improving outcome guidance has been on centralisation of cystectomy services. So this group looked at all the cystectomies registered on HES between 2003 and 2013, and to start with they determined which of the cystectomies were performed in a compliant fashion, i.e. in a unit that did more than 50 pelvic surgeries a year, or with surgeons each doing more than 5 cases. And over the 10-year period, the compliance improved dramatically. So in 2003, 52.7 cystectomies were non-IOG compliant, and that had dropped to 2%, which is an amazing reduction over a 10-year time frame. And then looking at the outcomes in relation to that, the crude mortality rate at 30 days was incredibly low by 2013. I think 1.5% mortality for cystectomy is something that we should be proud of in the UK. We also found that length of stay was favourable in patients who had their surgery performed in a cancer centre, and the overall survival was significantly improved. And I think it's well worth a read when it comes out in press. It's a very, very interesting paper. So I'm going to hand over to Hazel now, who's going to update you on the highlights from this meeting. Thank you.
Thanks, Alex. It's obviously a privilege to be able to come to speak to you. My brief, as it were, was to go through the bladder cancer from the session. So everybody has their abstract booklets or their posters on the Go app. And so as I go through these, it will be a race. And so you can always take note of the numbers and as we go through. We had a fabulous e-poster session. It was right at the beginning on Monday, exceptionally well moderated, really interesting papers, so much excellent work done, very well attended, over 150 people in the room. And obviously I can't talk about all of them. So I'm just going to start by rattling a few off. The first poster told us that we could probably cut down on our HSC 205 referrals to our haematuria clinics by 15% if we brought into proper discipline the NICE guidance and the asymptomatic microscopic haematurias could be taken out. They presented their data, they'd taken it back to primary care, and they'd got good consensus, and they had good data of how this was actually freeing up their time. It wouldn't be a BAUS if we didn't have a new urinary marker for bladder cancer. This one has been trialled in 76 patients in poster 9. Each patient needed to give us 250 mils of urine. We looked for cells in that, looking for the nuclear ratio. It probably has about the same amount of sensitivity and specificity as most of them. The hypothermia papers were well presented again, and particularly over the next 12 months we'll probably be hearing a little bit more about hypothermia. One using the combat machine, which is where the mitomycin is heated and put into the bladder. One using the Synergo machine, where the bladder wall is heated with radiofrequency ablation. Similar sort of patients in both studies actually. High-risk patients, largely failed BCG, and at a year they had good disease-free survival of around about 2/3. It wouldn't be any cystectomy talk at the moment or anything in oncology without the robots getting in there, and obviously there was a big debate between open and robotic. But before I go into the expensive, poster 4 was about a £49 Fitbit, which was about prehabilitation prior to cystectomy. So they were trying to get their patients to do 10,000 steps a day prior to their cystectomy through their neoadjuvant chemotherapy. The average for most of us, that says 300, doesn't it? It should say 3,000 to 4,000 the average person has, but the MDT members were managing 8,004 as average, so we've got a bit more to go as well. But we talked about this being quite empowering for patients to be involved in their own care. On to the robotic papers. There was a good paper, poster 11, about 5-year outcome data comparing robotic to open. The open cases were probably slightly more likely not to be organ confined and slightly more likely to be lymph node positive, but they concluded that the principle of the robot was to reduce the short-term morbidity, but the technology was unlikely to impact on the oncology, which I guess is a no-brainer. Paper 12 talked about cystectomy in the over 80s. What was remarkable about this paper is it used 6 tertiary referral centres from the south. And the bit that I picked out about this was the average time for cystectomy was just over 5 hours, but the range was 2 to 9 hours. Yes, 2 hours. So I don't know if there's a case report in there so we can all learn how to do cystectomy quicker. Papers 6 through to 8 were all, again, with the theme of robot versus open radical cystectomy. And I think the conclusion from them all is that the biggest benefit is actually coming from the introduction of the enhanced recovery programs. The winning paper was paper 7 from Newport, where they looked at 71 of their open radical cystectomies since they brought in their enhanced recovery, and they compared themselves to the published literature in the robotic series. And basically, they were equivalent. Their 90-day complication rate was lower, and they stated they were saving over £1,000 per patient. However, we then got the Guildford paper, which is a new service using the robot and enhanced recovery program, who was trying to introduce the concept of a 4-day inpatient stay as potentially the new standard that we should all be working towards in cystectomy. Part of another interesting quirk of this paper was the eldest patient they did a cystectomy on in their unit was 76 years old. But they did get 65% of them discharged in under 5 days, and they had stunningly low complication rates and readmission rates. However, I'm probably more likely to be able to afford the Fitbit. The BAUS audit. It's always a marathon. It's always a big thing for us as a group to put our work into the BAUS audit. And therefore, I always get slightly excited when I see some of the data coming out. And we had some of this in our poster session. So they looked at 2 years' worth of audit, which matched to 65% of the HES data. We have 161 surgeons performing cystectomy. And they were grouped either by centre or by surgeon volume into low, medium, and high volume. The high volume centres were probably more likely to take more lymph nodes and use less blood. The minimally invasive had a shorter length of stay, but no other parameters particularly stood out. However, overall, as a group of urologists, is that hurry up, Hazel? Sorry, Joe. Is the positive margin rate was 10% and our neobladder rate is 5.7%. That's basically a quick paper that tells us neoadjuvant chemotherapy does work for the CISs, so trying to highlight a change in dogma. Surveillance in radical prostatectomy, and I will just take 30 seconds on this if I may, because I think this is important, is surveillance with radical prostatectomy, cystectomy, is probably going to come more to the fore. This paper from Guy's looked at 104 patients, about 30% developed recurrence. If they were asymptomatic, they were detected about 3 months earlier than if they were detected because their scan was done for symptoms. And from that point of them finding the metastases, their survival was 13 months versus 4 months, which was interesting, particularly now we have the world of immunotherapy. We had our single superstar, which told us a little bit about the molecular genetics all the way from Johns Hopkins, Trinity Bakwalava. 69% of bladder mutations have known targets. And I think in this coming next 1 or 2 years, we're going to start hearing about bladder cancer in terms of luminal, basal, B53-like. And one part that I could glean some things is the basal types are immune-rich and therefore maybe more amenable to the checkpoint blockade, so maybe something to go from there. We have our homegrown star who talked in the Brexit talk, which was fantastic, and I'll finish there. Thank you, Joe.
I'll get around it by opening the bladder cancer. Thanks, Hazel and Alex. Great job. Great job. I'll give you an extra minute for bladder. Okay. Next we have John Anning and Kenneth Mackenzie, who are going to cover prostate cancer. If you zip up those stairs, gentlemen, lovely to see you.
Good afternoon, ladies and gentlemen. Joe, thank you. It's a great honour to be able to present the update session for the prostate cancer part of this. It's been a great year, and from a UK perspective, a number of practice-changing papers. You'll all be familiar with PROTECT, 82,000 men plus screened, and of those, just over 1,500 randomized into active monitoring, surgery, or radiotherapy. The 10-year median follow-up data presented in the New England Journal of Medicine, and in essence, I just want you to concentrate on the writing in red at the bottom of the schematic. So it's showing the 3 groups, and what you can see is the chance of dying from prostate cancer in all 3 groups was low. In terms of the chance of going to metastatic progression over that 10-year period, again, the figures were low. And really, what's the take-home message? Well, certainly 10 years seems to be too early to deduce which treatment is going to enable you to live longer. But certainly, what we can say is, in the pre-MRI era, 44% of men on active monitoring were able to avoid treatment. Now, this paper was about the patient-reported outcomes or quality of life, and it received less airtime. But in reality, this probably is most useful in terms of counselling our patients. So it's looking specifically at the symptoms after treatment. The red line on the graph is radical prostatectomy, the yellow line's radiotherapy, and active monitoring's in blue. And I've just highlighted the sexual quality scores and the incontinence or urinary scores, and what you can see is the red line is certainly higher than the yellow line, okay, but after 6 months, there's some reclassifications come towards each other. So certainly there's no doubt that radical prostatectomy has an effect in terms of measured quality of life scores. But importantly, I mean, there was no significant changes in anxiety, depression, or quality of life. And again, we're only at 10 years. MRI at BAUS this year has really dominated. The PROMISE study, again, another landmark study designed to evaluate the role of MRI in the diagnostic pathway. So MRI versus transrectal ultrasound scan. 11 centres, and I just want to focus on the second line. I think the key to this is it was quality controlled and blinded. So in that, MRI was quality evaluated, and if you had a poor MRI scan, you had to do it again. And in terms of blinding, trust biopsies versus template biopsies were analysed in different places. Again, controversially, the significant cancer was deemed to be 4 + 3 = 7. And again, this is a schematic from the paper in the Lancet, but really, again, concentrate on the right-hand side. So if you look at the men who were randomized, and then if you look at the men who had truss biopsy, and on the right-hand side, they found no significant cancer, so that's 452 patients. Of those, a quarter had a significant cancer there by the 4 + 3 definition. By contrast, if you look at MRI, again concentrating on the right-hand side of the slide, so when MRI deemed by Likert scale that there was a low chance of cancer being present, there was a 1 in 10 chance of a significant cancer being present. Some of you will have read the paper in detail, and in answer to the critique about the 4 + 3 versus the 3 + 4 and what we treat in clinical practice, certainly the data has been presented and the sensitivities drop when you include 3 + 4. But I think the other key thing to take away from the PROMISE paper is this, that this wasn't a study looking at whether or not the MRI detected a lesion and we were targeting the lesion. So the data is yet to be presented whether or not biopsying the targeted lesion is actually key. So what it really shows is that non-directed truss performs poorly. MRI certainly has utility as a pre-biopsy diagnostic adjunct. Cost effectiveness is awaited, and quality control is paramount. And I'll come back to that later on. This study, so radiation. Many of you may have followed the literature over the last year, and from a radiation perspective, you will know already that androgen deprivation therapy combined with radiotherapy is more effective than radiotherapy alone. Some of you will also know that the CHIP paper has been published over the last year looking at short course radiotherapy, so 4 weeks of radiotherapy, and it is non-inferior to longer course radiotherapy, and that is practice changing. But this study is a little bit different. It's looking at salvage radiation. So in men who have radical prostatectomy, approximately 30% by old figures may recur biochemically, so PSA greater than 0.2. And this study was looking at combining biclutamide with radiotherapy versus the placebo alone, double-blind. Eligibility, T2 margin positive, T3 no nodes, and all the patients included had a pelvic lymph node dissection, although they didn't stratify which. And in order to be included, PSA between 0.2 and 4. Over 300 men in both arms, 24 months of biclutamide was the therapy, and the primary outcome, again for a cancer study, was good. It was overall survival. And these are the curves, and what you can see is that for overall survival, biclutamide was certainly effective compared to placebo alone, and there was separation there. Now that transcended survival, it transcended incidence of death from prostate cancer, and it also improved incidence of metastases from prostate cancer. There was a marginal cost though. So if you use biclutamide alone for that period of time, gynecomastia was a significant issue. So certainly when we implement this in practice, as I think it should be, then we need to consider tamoxifen and other agents to act for the gynecomastia. Moving forwards, I think, again, coming back to the best of British, there are a number of UK centres that are driving forward prostate cancer research, but also from a pragmatic perspective. So papers to go away and look at would include Caroline Moore's paper on reporting standards and also looking at quality control for your MRI scans, because it's not just the scan and how it's interpreted is important. I think in terms of risk stratification, we can go away on the nice characterization, and Vincent's paper from the Cambridge group looking at clinical risk stratification using simple measures certainly has a role, and certainly that could be combined and implemented very quickly. Sometimes we forget the patient pathway, and I just wanted to pick out this paper from the BJUI. It was looking at just implementing pathways for the increasing burden of patients we're all facing. So men treated for prostate cancer and avoiding their follow-up in the hospital setting. So developing algorithms that can be followed in the community. And that's something certainly I'm sure many in the room are doing, but it's been formalized in that paper. I tried to stay away from the laboratory, but the reality is that I think as urologists we need to get more engaged in the laboratory. We've heard a little bit earlier about checkpoint inhibition, and traditionally in prostate cancer it's been thought not to be effective. In terms of checkpoint inhibitors, essentially what they're doing is trying to make the cancer cells look like normal human cells. And the reason we think that prostate cancer has not been susceptible is traditionally because actually there are other factors involved and it's more complex. This paper in Nature is actually looking at the fact that there are things in the body that fly around as well that protect the checkpoints, okay? And then by addressing those things that are flying around in the body, you can actually then target the checkpoint inhibitors at prostate cancer cells and deem an effect. So it's hypothesis generating. Finally, I think as surgeons, we do need to drive studies. You've seen a number of UK studies that have changed practice. The trombone study is a study that some of you will be aware of, but I just wanted to highlight it. Declan Murphy's talked about metastasis-derived or dedicated treatment, but treating the primary and advanced disease is becoming more and more important. And this study is looking at the role of surgery in men who have 3 or less metastases. Look for the centres. If you have patients that might be suitable, certainly think about it, because developing surgical trials, if we don't make a success of the ones we have, will be difficult. And finally, you'll wonder why I haven't mentioned this paper. We've got Professor Clark, who will be talking about this afterwards. But again, I think it's a key paper moving forward. Kenny will just come up and he'll talk about the updates and for the session.
Hello, my name is Kenneth Mackenzie, and I'm going to talk about the highlights from the summer meeting. So, as has been mentioned already, image guidance in diagnosing prostate cancer is becoming increasingly important. This has been highlighted by the fact that a whole session has been dedicated to this year at BAUS. In that session, there was 11 articles which incorporated multiparametric MRI to some degree to assess diagnosis. From those studies that took place across the whole of the UK, there was high diagnostic rates identified in PIRADS 3 and above disease in keeping with the PROMISE trial. In conjunction with multiparametric MRI, fusion technology has also been discussed. Cleverlin et al. In a multi-center trial using multiparametric MRI fusion technology in transperineal biopsies showed a high diagnostic rate, but importantly, they also showed a high negative predictive value when using PIRADS 1 or 2 disease and a PSA density of less than 0.1. For all those departments, though, that don't have a fancy fusion technology, there was good news because 2 papers showed that trust cognitive biopsies were as effective for fusion biopsies in clinically significant prostate cancer in lesions that are PIRADS 3 and above. There seems to be the debate that was continuing, even reviewing the abstracts, this was seen. So what is clinically significant disease? The papers were effectively split, with half going with clinically significant being greater or equal to 3+4, and then others following the PROMISE trial and agreeing that it was greater or equal than 4+3. This is something that I don't think I'm going to be able to answer for you today. As I've said, that imaging is really important. However, the gold standard for diagnosis is still biopsies. Transperineal biopsies are increasing and with lower rates of infection. However, Trussman biopsies are still a really important part of the diagnostic process. So thinking about infection is still very important. Hadjipavalou et al. Showed that tailoring antibiotic prophylaxis to rectal swabs in 314 patients did not have any significant difference in their infection rates compared to standard practice. So moving on from diagnosis, as has been mentioned already, Ganapaskiam et al. Presented their Cambridge prognostic groups in 2 very large cohorts and showed that they had better rates of predicting prostate cancer mortality compared to the standard 3-group classification by NICE. So this is something that may develop further into clinical practice. And then this is a meeting about celebrating Britain. The UK data registries really are a celebration of that. The BAUS data set showed that high volume centres with high volume consultants led to lower positive margin rates, transfusion rates, and shorter length of stay. Also, Annin et al. Showed that surgery for high-risk disease is safe, although they did identify that a third of high-risk patients did appropriately underwent extended pelvic lymph node dissection. So this is something that is potentially a benefit of the registry. Also reporting was the MPCA results, and they've shown that for robotic prostatectomy, there was improved rates when it comes to the complications. Also, there was discussion about over-treatment or under-treatment of potential disease groups. However, these would need to be evaluated further to fully understand those outcomes. Together, though, it does highlight that potentially evaluating outcomes as part of the BAUS data registry may be the important next step forward for prostate cancer. And then finally, as outcomes are so important, there were further treatments that were discussed. So Rai et al. Discussed their NeuroSafe technique, which improved nerve-sparing rates and also showed an improved rate of ED. Mosconis et al. Described a Ritzy-sparing technique, and they showed improved rates of continence at a short time period following robotic prostatectomy. And finally, Shah et al. Talked about local management with focal cryoablation, which showed that 98% of patients did not go through whole gland treatment with a small re-intervention rates, and complication rates were also comparable, and that was across the UK. So in summary, it appears that the practical application of multiparametric MRI across UK centres is showing good diagnostic rates, and also there is a real success in the data registries that should be celebrated, but we should maybe think about adding in outcomes to that area of assessment. Thank you.
So, thank you very much, John, Kenny, and last but not least, we have the renal cancer team, Hassan Kazi and also Maxine Tran. Go ahead.
Thank you very much. I'll be talking about four main areas really, in terms of updates for kidney cancer over the last year. Nephron-sparing surgery, locally advanced disease in terms of surgical developments, and metastatic disease. First, nephron-sparing surgery, any further evidence that it's better? But actually there is meta-analysis looking at partial nephrectomy versus radical nephrectomy. Fairly large cohort. This was the first one that incorporated large T1 kidney cancer, and they deducted that yes, absolutely it is better, number one. What is it better in? It's associated with a shorter hospital stay, better renal function, and that's not really information we didn't know. However, of interest was this study from JUROL last year, something that Montrose had started the year before. And they looked at, again, a fairly large cohort, a couple of thousand people, and looked at 10-year all-cause mortality and cancer-specific mortality, and they deducted that people who benefit from nephron-sparing surgery are people with a high comorbidity to start with. So interestingly, the people that we are sometimes trying to avoid taking on for nephron-sparing surgery are the ones who benefit more. Ongoing debate, how is nephron-sparing surgery best achieved? Well, there's been lots of discussion, certainly at the EAU this year. And Firefly, obviously, as the world of robotics is taking off, is taking in more and more clinicians. Few questions. Is the Firefly better in terms of tumor identification. The jury is still out. 27% of tumors are still isofluorescent, so not necessarily. Is it easier to define tumor margins to lower positive surgical margin rate? Again, ongoing debate. We know that in larger centers, tumor margin rates are very low. And does that translate into clinical significance? Possibly not. Does it help reduce warm ischemia time? Well, there's only one study looking at 42 patients. People who had Firefly-assisted partial nephrectomy did better in terms of renal function at discharge, but at 3 months, they were quite the same. And finally, any alternative? And the answer is yes, intraoperative Doppler ultrasound scan, which tends to be cheaper. So, question, this was an interesting presentation at the GGU earlier on the year. World-leading surgeons showing off what they can do in terms of partial nephrectomy in the absence of Firefly, and the answer is yes. You can still operate without the Firefly. So currently, in terms of nephron-sparing surgery, Firefly literature is relatively sparse. We are already at the edge of affordability for robotic surgery, and Doppler ultrasound scan can be fairly similar. So the bottom line is, if you have Firefly, feel very privileged. If you don't have it, it's not a huge problem. Moving on to locally advanced disease, 2 main areas, lymphadenectomy, which has been discussed quite a lot. So again, Gershman went on to publish another fairly large series, 2,000 odd patients, radical nephrectomy with or without lymph node dissection. And they looked at a propensity-based score analysis. And again, contrary to some previous studies, they did not find a significant difference in terms of overall survival, match-pairing people with similar disease, which was non-metastatic. So lymphadenectomy, is it necessary? And the answer is not nearly at this point in time. And of course, moving on to the world of robotics. So this I found was very interesting. Indy Gill's group, and they published level 2 and 3 inferior vena camus thrombectomy and the outcomes at 1 year. Again, if you look at the paper, very elegantly described a couple of extra assistant ports, but they demonstrate that this can be done well, efficacy in time, and certainly in terms of 1 year outcomes, they are very similar to what we are used to in terms of open surgery. So this really is the key area of development surgically, and over the next year or two, I'm sure the world of open surgery might be squeezed a tad based on these concepts. Now, moving on to metastatic cancer, and certainly I remember as an SHO coming to the first BAUS in 2002, and things have completely transformed for metastatic cancer. The world of surgery and TKIs only is well and truly over. This is a bit of a timeline, and I'd quite like to talk about nivolumab, cabozantinib, and combinations of treatments which are currently being used. The trials that have caused these agents to come into practice predate the agents used by a year or so. Now, 3 main areas which are being looked at from an oncological perspective in terms of first-line treatment and second-line treatment. Any other TKIs, so cabozantinib is one agent that's of extreme interest. It is going to be used as first-line and in treatment failures. Checkpoint inhibition, which of course we've talked about, and combinations of previous drugs that hadn't been used, which have a better outcome. Now, again, just a synopsis of a number of trials which have looked at patients who've had anything beyond first-line treatment. And I'll talk about the last 3 because these really have had profound impact in terms of how we are managing these patients, certainly over the last year. Checkmate 25, again, 800 odd patients. They were randomized to get nivolumab or everolimus, which was the standard of care for people who'd had treatment failures. These are patients who have been pre-treated already. And again, they found quite a significant difference in terms of overall survival, hazard ratio being 0.73, meaning that nivolumab was associated with 27% reduced mortality. So again, significant difference. Progression-free survival, once again, higher with nivolumab. And this is an agent we will see more and more being used, certainly for treatment failures and in first line in the time ahead. Meteor, this looked at cabozantinib and everolimus, and this was again a direct comparison. Everolimus is the standard of care, or has been the standard of care for some patients who've had treatment failures. Once again, significant improvement in terms of overall survival. So cabozantinib, another drug, very useful in the time ahead. And the third area of interest in kidney cancer is that combinations of drugs that we have been using already are now being, or single drugs that we have been using already have now or are now being combined. So lenvatinib and everolimus, both used previously, were looked at this. This is a phase 2 trial, fairly small number of patients, 65 odd. And again, in terms of monotherapy with either of the two agents, the results weren't half as impressive. So the progression-free survival was doubled using a combination of the two agents. And finally, quite a lot of emphasis. So you have somebody with non-metastatic or high-risk kidney cancer, you remove their kidney. Should you be giving them any adjuvant treatment following surgery? And to this day, we don't really have an answer. It is licensed for use, but it is not being used. The one trial that showed a positive result was the S-track. Again, looking at sunitinib, and this showed an advantage. None of the other trials have shown an advantage, so while it's licensed, word on the street is not really being used. In summary, nephron-sparing surgery, the ongoing message is that it is beneficial, persists. Slight difference is it is probably even more beneficial in patients who have a higher Charlton-Stoll index and are more comorbid. Firefly versus ultrasound scan, the jury is still out. Both are good modalities in context of other surgical things in our armament. Lymphadenectomy, is it absolutely necessary? And the answer is no at this point in time. I know NICE guidelines are emerging in this department. Thrombectomy, it is going to be done more and more robotically. We have good results from 1 year. For metastatic cancer, nivolumab and cabozantinib are the two agents that we're going to be using. And adjuvant treatment, it is licensed but not necessarily used at this point. Maxine, we'll now move on. Thank you very much.
Hello. I'll only take a couple of minutes of your time. I'm going to very, very briefly go over the highlights of the renal cancer session. So naturally, I was absolutely delighted and very proud of Tana, one of our trainees who's won the Best E-Poster Award of the session, describing our experience and our use of renal tumour mass biopsies in our diagnostic pathway for small renal masses. In just a little over 2 years, so 24 months, 25 months of data, 266 renal tumour biopsies for these T1A, so less than 4 centimetre renal masses. We are very fortunate at the Royal Free in that we have got a very dedicated interventional radiology department and specialist uropathology input in that, so that we can provide the results that renal tumour biopsy in this specialist setting is a safe procedure. Only 3 out of the 266 patients had minor Clavian complications. All were very self-limiting, bruising and pain. 30% of these, so 78 cases, had benign histology following renal tumour mass biopsy. And within this information, 75 of those patients were then made an informed choice to go on to active surveillance. There were some concerns from the audience regarding the delay in definitive treatment and the delay in the diagnostic pathway, and we've shown that in our centre it adds on 26 days. To counter that, I think as clinicians I know we are guided by targets, and we do need to meet these targets, but in avoiding unnecessary surgery in 75 patients, I think that's quite a powerful counter-argument for that. And then very briefly, there was a great poster on presentation on CT-guided cryotherapy, just asking the question whether Laparoscopic cryotherapy is now obsolete, and I think quite clearly the move has gone towards CT-guided cryotherapy, and this is certainly what we do in our unit. It's safer, it's cheaper, patients prefer it, it's more accessible. And then there was a presentation right at the start of the session, looking at the BAUS data set over the last 3 years, looking at surgical volume, and not surprisingly showed that if surgeons who operate more than 40 cases compared to the surgeons who do less than 5 cases, there is a lower conversion rate, there is a shorter operative time, and improvement in length of stay. I'm just going to quickly finish on an update. I've been asked by Grant Stewart, who's chair of the Renal Surgical CSG group, to just mention that we are addressing the dilemma about optimal management of the lower end in nephroureterectomies, and there is a trial that they are thinking about, but before we can embark on a trial, we do need to look at actual current surgical practice, and so that the BAUS nephrectomy database is going to change a little bit, and there will be new fields which will be added in to the database so that you can complete, and I've been told that these will mainly be location of tumour, the management of the distal end, and then whether intravesical chemotherapy was used in these management. Okay.
Thank you very much, Maxine and Hassan. I'm very sorry to say I don't have time for questions, but I really want to say thank you so much to a fantastic panel who've done an amazing job. Only a couple of minutes over, guys, but really warm congratulations. Thank you.
Pleasure to invite Noel Clarke to the podium. Noel and I have been colleagues in Manchester for almost 25 years. As a little aside, when I started to work with Noel in Manchester, I warned him that I probably wasn't going to work as hard as he has, or continues to do, over that period of time. And it was one of the better things I think I said over that period of time. Noel has had a distinguished career on many fronts. He heads up the National Prostate Cancer Audit and has done that for a period of time. And he's been intimately involved in the Stampede trial. And we've just had a preview, so I think some very exciting data coming to light. Noel.
Thank you, Kieran. I'm not sure about the working hard a bit, but anyway, it's been a great privilege. If I could have the slides for Clark. What are we doing? Voting. Should be a presentation. I'm not quite sure what happens next. I think we've got the wrong sets of slides up. I think I'm a consultant. Well, I'm not quite sure what's happening to the slides, but suffice to say that it's usually a bit of a curse presenting last at BAUS, or indeed any meeting. But today it really is quite a privilege because it's my honour to report on behalf of the UK the results of the Stampede trial and its latest iteration. And Stampede has been a real success story, and it got rock star status at the ASCO meeting in Chicago just recently. That's a meeting of 38,000 delegates, and we were privileged to be able to present this data. And this is UK Inc. It's the world's largest prostate cancer intervention trial, and I think it's fair to say the world's most successful intervention trial. We've got 9,000 patients in the trial. We've about 3,000 site staff, and that includes all of you who participated in the 138 centres throughout the UK. This is the format, multi-arm, multi-stage. That in itself is innovative and completely novel. I won't go into that today. but suffice to say it has been practice changing, and in 2015 we produced the docetaxel zoledronic acid comparisons, which were published as a primary paper in The Lancet and as a meta-analysis of 3 different trials in Lancet Oncology. These were practice changing, but what I'm going to talk about today is the abiraterone comparison, which was standard of care versus standard of care plus abiraterone, 1,900 patients randomized in this arm, which was read out at ASCO this year by Nick James on behalf of the team, and was published the same day in the New England Journal of Medicine. These were the inclusion criteria, just to re-emphasize in case you don't know or remember. This was for high risk, as defined here, any metastatic, any node positive, or 2 or more of T3, T4, PSAs 40 or more, and high Gleason grades. And the primary endpoint was survival, with various secondary endpoints, which I'll talk about. We started to recruit in 2011 to this particular arm, and we closed in 2014. This is one of the most rapidly recruiting major cancer trials in the world, and is a testimony to everybody's efforts. We had pretty even distribution between standard of care and abiraterone, and this is how the patient characteristics looked. Roughly about half of the patients were metastatic, 88% bony, and the remainder were genuinely high risk, 20% clinically M0, 28%, 20% M plus, and the remainder N0, with only a small proportion who'd progressed from previous treatment. These were the defined primary outcomes: overall survival, and this is what the results showed. Now this, contrary to what was said yesterday, this is actually overall survival, but most of these patients, and these are M0s and M1s, were included here. There's a major difference here in the outcome. The hazard ratio overall was 0.63, and this was a 37% overall improvement in survival. This is the biggest survival ever reported in a prostate cancer trial of this type. And when we look across the various subgroups, you can look at the forest plot here, briefly, M0s and M1s, various lymph node stages, right the way across. There was no difference at all to suggest there was any heterogeneity. So if you got the treatment, you got the effect, and the effect was major. If we look at the overall survival by metastatic status, this was a pre-planned analysis, again, you can see that there is a major effect here. I'll come back to the M0s in a minute, but those patients who had metastatic disease had the best effect, but there was no heterogeneity across the whole trial. In other words, if you got the treatment, whether you were M0 or M1, you got the benefit. When we looked at the intermediate primary outcomes, failure-free survival, this is what we saw, which was an even bigger effect. Remember, this is M0s and M1s. And again, you look at the hazard ratio. This is the number of events over time, remember. The hazard ratio was 0.29, with a p-value of 0.377 times 10 to the minus 61. You don't need to be a statistician to work that out. A 71% improvement in time to treatment failure. And again, when we looked across all of the different subgroups, M0s, M1s, Gleason's less than 7 or 8, performance status, and so on, there was a homogeneity of effect, showing that the treatment effect was universal right across the different disease types. Now, there was a pre-planned analysis by metastatic status, and I want to draw your attention specifically to the M0s, because this was completely misunderstood by the American audience, who felt that this didn't represent an effect, largely because this one crossed a hazard line. But if you look in M0 patients here at the failure-free survival, there is an absolutely massive effect. So we had 142 failures in the standard of care, but only 38 failures in those who were treated with M0 disease with a combination. And if you look at that in a survival plot with a hazard ratio, the hazard ratio was 0.21, so a massive reduction in progression rate in high-risk M0s. And we know that about 50% of these progress within 5 years, and about 1 in 5 will die during that time. Other secondary outcome measures of relevance, well, skeletal-related events were much reduced. The HR, again, 0.46, and that was a 55% reduction in skeletal-related events in metastatic patients. And as we all know, clinical skeletal-related events, which these were, are very unpleasant, pathological fractures, cord compression, and so on. And if you can reduce that by half, well, perhaps that's worth having. Looking at safety, these treatments were very well tolerated. And when we look at the overall standard of care here, plus abiraterone, the various grades of complications, there was a price to pay, a somewhat increased rate of complications, and here are the complications in the main. They were mainly cardiovascular disorders, largely hypertension, easily managed, and changes in transaminase effect. And again, these were very easily managed by dose reductions and treatment holidays. They just needed monitoring in the main. So in conclusion, on the basis of this definitive work, which was backed up by a second trial conducted on the international circuit, the overall survival was improved with the combination of androgen deprivation and abiraterone by 37%. Failure-free survival overall by 71%, and there was almost a 50% reduction in skeletal-related events. The treatments were well tolerated, and we think now that this is the standard of care for men starting long-term androgen deprivation therapy when they have high-risk and/or metastatic disease at first presentation. The paper detail is all in the New England Journal of Medicine. As you can see from the trial management group here, we're all smiling, and that's because this was taken when we first read out the results. They're far, far better than any of us ever predicted. And really, I'd like to extend the thanks to you all out there in the UK, because without these centres, this kind of data, which is a world-leading trial, would not be available for practice changing today. Thanks very much.
So, Noel, we've time for a couple of questions, and I guess the obvious one is the cost in terms of moving forward now with this newly defined standard of care.
Well, that will be the next critical question to answer. We've done a meta-analysis of all the trials so far, which included Latitude, the international trial, and ours. There's a clear homogeneity of benefit. We've done the cost analysis for docetaxel. We're about to publish on this, and actually giving docetaxel up front is far more cost effective than giving it later. And I suspect that when we look at the cost effectiveness, the cost benefit from giving abiraterone early, it will far exceed that for giving it late in metastatic. The big question, I think, really relates to M0 disease, because we have the opportunity, I think, to have a relative cure for many of these patients. If we think about the age, we think about pushing back the time to progression, then that, whilst it might be more costly, I think is going to be an absolute benefit for those patients.
What is the future of the urologist actually prescribing these medications moving forward because of this traditional problem with our oncological colleagues?
Well, you know my feelings on this, Kieran, which is that urologists absolutely have to get engaged with this. And if we don't, we'll lose the patients completely. I'm not saying that every urologist should give these drugs, but I think that urological oncologists, and there are a number of you in the audience, should be right at the forefront of this multidisciplinary care. We have to get engaged with it. And I think the use of abiraterone, or this new data, enables us to take back the control of some of these patients, because we should be able to give this right at the outset, rather than to have to send the patients to a non-surgical team to give chemotherapy.
Any further questions for Noel? Well, Noel, they've been out last night. You have stunned them, I think, so thank you very much for your contribution. Well, we're almost there, and there are just a couple of things that I would like to do over the next few minutes. One is to pay tribute to you for coming along and making this meeting, I think, very successful. I felt a real buzz around the place over the last couple of days. And that success is largely due to the hard work of Duncan Somerton and Paul Jones in terms of putting the programme together. We took a punt this year. We recognised that we were up in competition with the European Society of Urology. We know that a large number of British urologists were keen to go to the meeting, and we felt that it was an opportune time to try something different, and hence we got rid of the courses, or a number of the courses, and we condensed the programme to 3 days. So with your indulgence, I'd like to just get a little bit of feedback. If we could have the slides. You've got your mobile phones there, and I just have a couple of questions really relating to the audience that we have and then how the meeting has progressed so that we can take the temperature. I should stress that all of you will be getting a survey, and having completed the survey, then you will be getting your CPD certificate. It is hugely important for us to be able to plan high-quality meetings, and that feedback is very important, warts and all. So the first question is, what type of delegate are you? I guess you'll still remember. Okay, so we have a large proportion of consultants in the room, approximately 60%, and in around 22% trainees and 10% urology specialists. Moving forward, and this is quite pivotal now, so BAUS actually paid for a 4-day meeting. We've hired the venue for 4 days. We've hired the venue next year for 4 days. But the issue for you really is whether you would prefer a 3-day or a 4-day meeting. So if you could vote on that, please. So almost 80% of you would prefer the 3-day meeting, and that certainly represents the feeling that I've had talking to lots of people over the last couple of days. Now, one of the things that we do is that we invite a number of people to come along and speak to us, and it's important that we have a kind of an idea of how well that works. So these next 2 questions relate to that. So the contribution of our invited speakers, how would you rate them? Okay, so it's almost 80% regarded as essential or very, very attractive, and so that's very informative. Now, because this year was the best of British, I was keen to get an idea of how you rate the contribution of international speakers in relation to the meeting. We're in the middle of Brexit, we're going forward. Should the channel be cut off or not? So the contribution of international speakers. Okay, so that sends us a very clear message in terms of continuing to be outward looking and trying to get the best possible international faculty to come along and speak to you. So we have changed the meeting this year with a reduction in the skills and teaching courses. That has meant, I think, that the sessions have been better filled. There have been a greater concentration of people in the sessions. So do you think that it has detracted from the meeting? Because there's been some comment about that. So perhaps a yes or no. Okay, so no, so approximately 70%. So that seems to vindicate the decision, and we will look at that carefully in terms of the feedback that you and others will give moving forward. Okay, so that's the final roundup. A simple advert here telling you that we have arranged now to go to Liverpool on the 25th of June. It only remains for me to thank you for coming along to the meeting and making it such a success, and to the team who have helped put this together. Thank you all.